It's another day with the physicians where your health is our business. It grows towards the end, so you are not going to take some drastic measures. But a 10-year-old coming,
pressure is high, but also to know that it's not only when your pressure is high that you have glaucoma.
Sugar, and I don't know about any other one, but what do you know?
You're welcome back to the training also of your regular program.
Urticaria or hives is a skin condition that is characterized by raised what we call wheals or swellings on the skin.
many, but not all women who have had mastectomy to treat breast cancer go on to have on or both breasts reconstructed. There are many ways to reconstruct a breast. Tissue from the back, belly, buttocks, or other part of the body can be used to create new breasts. Doctors call this autologous reconstruction. Breast reconstruction can be done at different times depending on what works best for the woman's individual situation. When breast reconstruction is done at the same time as mastectomy surgery, is called immediate reconstruction. The goal of immediate breast reconstruction is to optimize a woman's quality of life and maintain her body image. She wakes up from surgery with a new breast or breasts and doesn't have to wear a prosthesis or have a tissue expander in place for several weeks or months. Today on your favorite health TV talk show, The Physicians, we will be talking on autologous breast reconstruction after mastectomy. It's your favorite health TV talk show, The Physicians, where your health is our business. My name is Dr. Memuna Yusuf Kadri, and of course, with my regular co-host.
My name is Dr. Martina Agbere. Welcome to The Physicians, where your health is always our business.
You know, today we're talking about autologous breast reconstruction after mastectomy.
Yes, after mastectomy.
Yeah, big English there.
Yeah.
Breast
autologous simply means the same.
Yes.
Okay. It's not from
breast
another
reconstruction.
Then mastectomy, that's the removal of the breast. So
because we have to break it down for our
because of our audience. So mastectomy, removal of the breast.
It can be one, it can be both, depending on what the issue.
So an autologous itself. So within.
Okay,
yeah. So that's what we're talking about today, autologous breast reconstruction after mastectomy. So it simply means
after the removal
of the breast, what next?
What next? Do you leave it like that? Or do you, for aesthetic reasons, you put something there?
Or you want to use your own, anything from your body parts to replace it. Okay, well, you know why I'm actually interested in this topic? It's because knowing that we have experts that can actually handle this
in Nigeria
without living.
Without living, yes, you are right. And for us in the physicians, that is our goal. You know, creating awareness on health and health-related issues, beaming the light on experts that know how to do these things that you can source for locally. And there have been, you know, a lot of success stories when it comes to, because when it comes to health, we always want to hear the extreme, the worst-case scenario, death.
And it really reduces the medical authority.
A lot.
And our forex will save.
Will be saved.
So, and even the common man is able to achieve the same result. So let's roll with the physicians.
We'll be right back after this timer. Stay tuned. Welcome back. If you're just joining us, this is your favorite health TV talk show, The Physicians, where your health is our business. Today we will be discussing a very important and essential topic, not only for the health benefits, but also for awareness and reducing medical tourism. The topic is all about autologous breast reconstruction after mastectomy. And with us in the studio is an expert, a walking encyclopedia, who will be sharing more light on this topic today. Please help me welcome Dr. Abdulwahab Ajani Olanrewaju, a consultant plastic and reconstructive surgeon with Lagos State University Teaching Hospital and a lecturer with the Lagos State College of Medicine. You're welcome, sir.
Yeah, thank you for having me.
Welcome. Nice seeing you again.
Thank you for having me.
It's true. Nice seeing you again, sir. This
It's
is
always a pleasure.
It's always a pleasure. And today's topic, like I introduced, a lot of people need to be aware that we have, the experts that do this work right here in Nigeria without crossing the borders. So, sir, please, I want you to shine light on what, because we use a big terminology. Mastectomy. If you are not a doctor in the health, autologous, they were like, what are these people talking about? Please help us break it down to our viewers, what mastectomy is, what autologous is, what reconstructive, breast reconstruction after mastectomy. So those terminologies can be like, okay, we understand it now.
Yeah, thank you very much. Mastectomy simply means surgical removal of the breast, most of the time due to breast cancer. There could be other reasons why you want to, remove the breast, but most of the time is due to either early or late breast cancer. Okay. So, and this is done by the breast surgeon, and it's after the removal that the plastic surgeon comes in to either replace it with an implant, or you use part of the tissue of the patient to reconstruct it, that's why it is termed autologous, which means what you are using is coming from the same patient, and you are not taking it from any other person, or you are not using any implant. Okay. So it's coming directly from the patient tissue, and that's why it is called autologous.
Okay. So what does it really entail?
Basically, when I was in my first interview with you, I said that one very first principle of reconstruction is to replace like with like. So since the breast looks more, the fat is the easiest tissue that looks like the breast. So we look for any part of the body that has a lot of fat, such as the part of the abdomen that is below the umbilicus, the thigh, the buttocks, and any other part of the body we can harvest fat. Those are the areas we go to harvest tissue to reconstruct the breast.
So, aside from breast cancer and whether it's early or late stage and it has to be removed, are there other specific medical conditions that somebody may want to have a reconstructive surgery? And what are the, how often do this reconstruction fail?
Okay, thank you very much. Apart from breast cancer, infection, which we call necrotizing fasciitis, can eat up the breast.
Oh.
So in that case, we have to, if the patient wants, we can do a free tissue transfer to reconstruct the breast. Also, some benign tumors too that are not cancerous that may disfigure the breast. We may need to remove and put another breast. So these are the few cases, but the majority of cases are due to breast cancer, as I said in my introduction.
Okay, so for after the mastectomy, right? How long is the patient expected to wait before you do the surgery? And have you had instances where there is it's like a graft, right? Have you had Have you had instances where there is a rejection?
Yes, that's the beauty. That's why we call it autologous. Since it's coming from the patient, there is no fear of rejection. So, and there is no need to be on immunosuppressants for life. The tissue is not coming from an outsider. It's our own tissue. So there is no fear of reaction to whatever we are putting there. And the reason why it is called autologous is because it's the patient tissue. So what was the first question? Sorry.
How often does the rejection?
Okay, rejection, no, there's no rejection.
Autologous, yes.
No, I said after the surgery, after the mastectomy,
yeah, it depends.
how long should the patient wait before you do the
That's why I said in my introduction, it depends on when the patient presents.
Okay.
Whether the breast cancer is early. If it is early and we are able to remove the whole breast tissue, we can do it at the same sitting without giving time. But if it is the late type, we allow the patient to go through adjuvant therapy, which means either chemotherapy or radiotherapy. So when she's disease-free for a year or two, she can then come back for the reconstruction. Because we want to be sure there is no tumor before we do the reconstruction. But some of them can have the implant-based reconstruction initially, so that the psychological effect of losing a breast will not be there. So we do a temporary reconstruction with tissue expander, then the implants, either silicone or saline implants. Then when she wants to change to autologous, we can remove the implant and put our own tissue.
So from what you are describing now, the autologous is quite safe.
Very safe, very safe. That's the beauty, because it's the patient's tissue. There is no issue of reaction or changing from, using drugs for life, like renal transplant and other types of transplantation.
But are there some little unforeseen rare complications that could arise?
Of course. Even with minor surgery, there might be some complications. And if you do your surgery meticulously, the complication rate is not more than 2 or 3%. Like bleeding, that's immediate during surgery. Once you secure hemostasis very well, you use your diatemy, all those ones will be reduced. Then after surgery, there might be what we call seroma formation. So in this, if you close the abdominal flap very well by quitting it to the rectus fascia, that one will be reduced. Another way we can reduce that is by using drain. But most surgeons now are no longer using drain, because they do the dissection very well and also secure hemostasis very well. So there wouldn't be fear of blood collecting under the abdominal flap. So with this, the complication rate is very minimal. And also the success rate. In most centers around the world now, success rate is close to 96%.
Really?
Which is very good. So, but in this environment, our success rate range between 90 and 95.
That's good. That's good. Okay, so I want to ask, in our environment here, okay, you are the one on the field.
Yeah.
How often do you see patients come for breast reconstruction?
Well, the awareness is not there yet. The few patients we are seeing are the enlightened ones that maybe they've traveled abroad and they maybe for one reason or the other they may not be able to go there and they settle for the local reconstruction.
Okay, so I want to ask.
It's not popular among the Even some of our colleagues are not aware that these things are
just
possible in the country.
why don't, is it not possible for you as a plastic surgeon work with the other general surgeon?
We do.
So that because I'm trying to bridge the gap between the haves and the have-nots.
Yeah.
Okay, so that if they see these patients, they are able to refer them to you.
Yes.
So that the patients are aware that it is not only going out and having silicone and all those other ones, implants.
Yeah,
that are necessary.
that's why it's good to be in a teaching hospital. You know, we have general surgeons who specialize on breast.
Liaison.
And so we all collaborate. Once they see a patient that wants it, they refer to plastic surgeon, and we do them.
So do we get people that just on their own, they've not done mastectomy, they just come for reconstructive, you know?
No, those ones...
Just hold on to that question.
Okay.
We'll be right back after this time out. We're going on the street to talk to you. We're keeping up with the physicians. And let's hear your own view when it comes to reconstructive surgery, breast reconstruction after mastectomy. We'll be right back after this time out. Stay tuned.
For those that feel it's necessary, that's why they do it. And some people can't stay having one breast or stay without having any breast. So I think that's why they always reconstruct. And some do it because of fittings and, you know, they just want to see it the way they like it. That's why.
Yes, some people go for breast reconstruction because there are some that maybe their breast is so small and they think that it will not match or fit the clothes they are wearing. So because of that, they will go for breast reconstruction. And some even feel because of maybe their man, because of men, they just feel like, okay, the breast is not big enough. That men love the one that has a very big boobs. So because of that, they will just go for construction.
Really, I've never heard of it before. Today is my first time hearing it, and I don't know how it is, but I think waiting doctor no fit do, I think it's possible.
Yes, I know that another one can be reconstructed from the body. Yes.
I prefer the one from skin, the person's skin. I don't prefer the artificial one, because there may be some things that will affect that person in future.
I will prefer part of the body, because for them to use parts of the body, the doctor or the surgeon must have do some tests to check if the cell's cancer is not part of. It's not that place that they want to take the flesh from is not cancerous, so they can use from it. So it's okay.
In my own way, for me, I feel that artificial can go far, because the skin, I feel the person is still going to feel more pain, because cutting out of the skin and still reconstructing on it without that place getting healed and all those stuff. So I feel the artificial one is better. Let's it just be that it's one-sided, and that's just it.
Welcome back. We've been having a lot of knowledge, enlightenment, and we are taking it all in on your regular and of course favorite health TV talk show with the physicians, where our guest, a consultant plastic and reconstructive microsurgeon, vascular surgeon, Dr. Abdulwahab Ajani Olanrewaju. So I asked the question before we went on break, like, do people just come and say, I want breast reconstruction? They didn't have any mastectomy, nothing. But
yeah, that's what I was trying to say before we went on break. That we don't categorize it as reconstruction. We classify it as aesthetic surgery.
okay.
So it's a separate field.
So it's a separate field.
We do it, in fact, we do that more than even
The reconstruction,
yeah.
right?
The patient presents for that more than the reconstruction.
Because it's for aesthetics.
Yes, exactly.
Okay, so
because in that, nothing is missing.
You
You just want it to be better. So we do that a lot.
Okay, Dr. Ajani, knowing that you are a plastic surgeon and a microvascular one at that, Before I continue, how many are you in Nigeria? How many of microsurgeons
Microvascular
surgeons we have in Nigeria?
Well, my knowledge is just Lagos.
Lagos.
And
So in Lagos, how many are you?
We're about 2 now.
There are just two in Lagos.
Yeah, but
You
I
need to
can't
be in
talk
the
of-
museum. So you need to be in the museum. We need to preserve you.
Why?
Because you are a treasure,
Wow.
national treasure.
So because microvascular means you pay attention to details, the minutest
Yes.
of all the vessels.
Yes.
Okay, so now let me ask you, we're coming to terms with reconstruction after mastectomy, okay? How long does it take after surgery for it to settle? For that reconstruction I have done, for that breast to settle, how long does it take? Because you have taken a part from one
Yes.
part, and how long does it take to settle before the woman says, yes, I'm fit, I'm good to go?
3 months.
3 months.
Because it's not just doing the breast. We see do what we call balancing. Maybe the other breast, we want it to be symmetrical. So we do either a reduction or augmentation on the contralateral breast. Then we also do nipple areolar reconstruction. So before we can attempt to do anything on the reconstructed breast, we give like minimum of 3 months.
So where would you get the nipple from if you are getting the other
So
part of the
many,
breast?
so many places.
Nipple areolar reconstruction.
That's not for.
So that's not for the viewer. It's not for the.
So many
They are,
places you
they
can.
are the surgeons, so they know exactly what to do, where to get
It's
it from.
interesting.
Even if you want sensation, we can still put a nerve graft. to
Seriously?
it. Yes, I mean
what is
it's
the minimum number of hours for this kind of surgery?
10 hours.
Excuse me?
10 hours. Yes.
You stand for 10 hours?
Sure.
Wow.
This is interesting.
No break.
Then we can have break in between, but it may last
Wow.
up to 10 hours.
10 hours.
So which is the safest breast reconstruction surgery? The safest to do? This autologous or the...
The quickest
The
and
quickest,
safest
safest.
is the implant base.
Okay.
Because that one may take just 1 hour. You just create a pocket below the pectoralis muscle and put your implants.
Okay, now we need to debunk something because people have talked about using the silicone.
Yes.
And at times it will rupture, it will burst.
Yes, those
So
are
how challenges? What are the? Yes, let's
those
talk
are
about
the
that.
complications. Well, I thought the topic is just autologous, but if
Yeah,
you want
because
us
now that we have you,
Yeah,
now
now
that
that
we have you, you're just in Lagos. Now that we have you, let's
no, there are
yes.
many people that can do the implant-based
implant
reconstruction.
based,
It's not the only one you need a microsurgeon for is the autologous.
Reconstructive.
So
okay.
any other plastic surgeon can do
the
the
implant
implant-based. Yes.
So, but aside, there are those common myths, it will burst. What could even result into that? Is it the body rejecting it, or maybe infection or something?
Yes, infection is one common cause, and also pressure or trauma from the outside.
Oh.
Yes, they can rupture the
So they have
implant.
to be careful too.
Of course.
Because that's a foreign body.
It is a foreign body, really, really. Oh my goodness! It's okay. Let me ask you something. For the ages, do you think for the age groups, which ones have you seen most
The
common?
commonest, yeah.
The below 40.
Below 40.
No,
Yes.
No.
I mean, I thought for the aesthetic, for the breast cancer group,
Yes, but of course the studies is
50 and
understandable.
above.
Okay, 50 and above. Okay.
50 and above for
Okay.
for the reconstruction.
Okay. Are there possible complications?
Of which procedure? The autologous?
Yes.
Of course, many. Intra-op, patient can have bleeding, as I said earlier. Then post-op, they can have seroma formation. The wound can be infected. Also, the wound can break down, and you have what we call wound dehiscence.
Okay.
Then also the flap can necrose. You can have what we call flap necrosis.
Okay.
So there are so many complications that can come. But as I said in my introduction, if you plan your surgery very well, do all the investigations, and do your dissection and secure hemostasis very well, all these complications can be reduced to 2 to 3%. Yes.
So I'm not putting you on the spot, but this is a question I know our viewers will definitely ask us when they watch this program. How affordable is this? The breast reconstruction after mastectomy?
In my center, we charge the same amount as other major surgery. I may not be able to disclose the amount, but it's just affordable. Like, it's very affordable.
Wow.
Very affordable in LASUTH. But I can't say of any other.
So is it only in LASUTH that you have this surgery done? How about the other teaching hospital? Just for the purpose of our viewers.
Well, for those that there are many other centers that can do it, but they may not transfer it as a free tissue. What I base my own reconstruction on is to lift the tissue from wherever I want with the vessel and take it to the breast and anastomose. But there are other means by which you can transfer the tissue without doing microsurgery.
Okay, so let me ask another question. Sorry, because you are just two in Lagos.
Yes.
I don't know where the other doctor is. If it's also in LASUTH. So. Okay, so we can have doctors, patients being referred to you from other private hospitals.
Sure.
Okay, that's just I want to be sure. I don't want to hear that both of you are in the same hospital, because
we work together. we collaborate.
So, but because you are few, are you sure you are based in Lagos alone? You have patients being referred from other places?
Yes, absolutely. From all over the country.
Okay.
Yeah. And he also goes to other places to do that,
yes.
which he has also explained here. Okay. So, for every surgical condition, if I'm medical, health related, we always advocate for this aftercare. Yeah. How great! I want to use a very positive word. I don't want to think the way we think in Nigeria. How great is our aftercare after breast reconstruction?
Very fantastic, because as I told you in my introduction, it's a teamwork. Once we finish our own aspect of reconstruction, we send the patient back to the general surgeon and they continue the follow-up.
Thank you so much, Dr. Abdulwahab Ajani Olanrewaju, our national treasure.
Yes, real national treasure.
One of its kind, one of the two plastic and reconstructive microvascular surgeon in Lagos. In Nigeria, because I'm sure the other few people that are there, but they are not.
No, I said Lagos.
Lagos, but Lagos is set place for so many other people.
No, we need to know what is going on in the country before I can say that.
Thank you very much, sir. My name still remains Dr. Memuna Yusuf Kadri. Until next time, stay.
I want to join Dr. Memuna in saying thank you so much for honoring our invitation, coming on our program. I'm sure our viewers out there actually did benefit. And it's actually a privilege having you again as our guest, one of the very few microvascular surgeons. Again, I remain Dr. Martina Agbemi. Remember to follow us on our social media platforms, on Instagram, on YouTube, on Facebook. Don't forget to send us a mail. Go to our website, which is up running, and send us a mail so you can be part of our program. Till next time, stay blessed.